Barabar. So this will happen in renal. This will happen in renal failure because the renal tubules are responsible for the final hydroxylation step
Yes, sir.
of the vitamin D.
Yes, sir.
Barabar.
Yes.
So now, जो अमित बता रहा था tertiary, that is actually secondary only. So what happens in tertiary is that after a very prolonged period of secondary hyperparathyroidism, right, the parathormone from the parathyroid gland, it becomes autonomous.
Yes, sir.
वो उसको गुस्सा आ जाता है. वो बोलता है तुमने मुझे इतना मेहनत करवाया है, इतना मेहनत करवाया, इतना मेहनत करवाया, अभी मैं नहीं रुकूंगा, तुम लोग जो करना कर लो. राइट. सो इट्स लाइक तुम अभी कैल्शियम करेक्ट कर लो, विटामिन डी करेक्ट कर लो, सब कुछ बराबर कर दो, फिर भी पैराथर्मोन बोलता है नहीं, अभी मैं नहीं सुनूंगा, तुमको जो करना है कर लो. लाइक इट्स लाइक दैट. So it is an autonomous parathormone release from the parathyroid.
Yes.
After prolonged period of secondary hyperparathyroidism, it is the parathormone telling you fuck off. अब मैं नहीं सुनूंगा किसी की. ठीक है. So that's what happens in tertiary parathyroid. ठीक है. Now primary hyperparathyroidism is increased parathormone release from the parathyroid gland for no particular reason. Barabar. So what is the commonest cause of that?
Sir, hyperplasia, adenomas or hyperplasia of parathyroid gland.
No, which is most common? Adenoma or hyperplasia?
Hyperplasia.
महेश, तुम सच में महेश हो कि स्यूडो महेश हो? Adenoma is commonest, yaar. Adenoma is the commonest. Hyperplasia. So what is the difference between adenoma and hyperplasia? Does anybody want to tell me?
Hyperplasia is physiological proliferation of the gland, and adenoma is benign of parathyroid.
So basically, hyperplasia is enlargement of all the glands, of all the segments of the parathyroid gland, not some one focal specific area which is hyperfunctioning. Whole gland is hyperfunctioning.
Yes.
Okay. Parathyroid adenoma, there is a focal area of increased activity because वहाँ पे benign tumor तैयार हो गया है या something like that. Okay. So so that basically you pick it up in the sesame scan or in the PET scan. Whether it is, so suppose you have biochemically diagnosed hyperparathyroidism. You want to know whether it's primary, secondary, tertiary. Okay. Now you found out that it's primary. You want to know whether it's adenoma or hyperplasia, so you will do the sesame scan or the PET scan, which will uptake will tell you. So in adenoma there will be a focal uptake, and in hyperplasia it will be diffuse uptake.
Yes, sir.
Barabar? So now one more thing is this can be correlated very well to actually one more thing we study in the pancreas. Can anybody tell me what that is?
Insulin.
Correct. Yes. So insulinoma versus ये सब सिखाया है मैंने आपको, आई थिंक अभी तो few sessions back I told you, I think.
Somatostatin.
Nesidioblastosis. Nesidioblastosis. So nesidioblastosis is a islet cell hyperplasia, diffuse islet cell hyperplasia. बराबर?
Yes, sir.
Whereas insulinoma will be a focal area of increased insulin production. बराबर? So patients will basically have high insulin levels due to nesidioblastosis or due to insulinoma. And just 1 second. Na?
Yes, sir. This is pediatrics में common for hypoglycemia. Hypoglycemia hyperplasia होता है. Nesidoblastoma. Cells को शायद nesidio.
Hi. So islet cell hyperplasia and insulinoma we were talking, na?
Yes, sir.
Barabar? So so patients will present with recurrent hypoglycemic episodes, or recurrent fainting, recurrent falls, all those kind of things. And if you want to diagnose it, then what do you use?
Fasting insulin levels. C-peptide with
तुम्हारा वॉल्यूम कम हो गया रे सडनली.
volume. सर आ रहा है अभी बराबर?
नहीं, एकदम फेंट है.
फेंट है.
C-peptide levels.
C-peptide levels. Okay.
जोर से. इंसुलिन लेवल्स करेंगे फर्स्ट स्क्रीनिंग टेस्ट.
थोड़ा आई थिंक you'll have to speak loudly. अभी भी फेंट है.
नहीं यहाँ से म्यूट.
हेलो.
यस सर.
हाँ अभी आ रहा है सर.
अभी आ रहा है सर.
या है. हाँ हाँ. C-peptide levels.
इंसुलिन लेवल्स.
इंसुलिन लेवल्स. सपोज उसमें नहीं मिला तो क्या करेंगे? स्टिल सस्पेक्ट.
इमेजिंग में सीटी स्कैन. इमेजिंग कैन नहीं एक और ये था.
It's a hormone ना. Is there any provocative test, stimulation, suppression test कुछ है?
तो ओरल ग्लूकोज टॉलरेंस टेस्ट. डायबिटीज इसका नहीं. ग्लूकोज लेंगे तो ग्लूकागॉन का कुछ
Calcium stimulation test ना. Calcium stimulation test.
Yes sir.
Why calcium? You know, hypercalcemia is one of the causes of pancreatitis.
Yes.
Correct? When there
Yes,
is
sir.
severe hypercalcemia, there can be pancreatitis.
Pancreatitis.
Why? Has anybody tried to find out why? So calcium is a secondary messenger in a lot of enzyme systems.
Yes.
बराबर. Now, pancreas is one of the organs which is full of enzymes. So many enzymes are there which can eat up so many things. Barabar? So whenever there is too much calcium in the blood, and if it kind of diffuses into the pancreas, then it activates all of these enzymes because it acts as a second messenger for so many enzymes and enzymatic pathways. Barabar? So that is the mechanism of hypercalcemia causing pancreatitis. Barabar? So now insulin islets of Langerhans are in the pancreas. Now you are strongly suspecting insulinoma, but you're not able to prove it. So what will you use? You can use a calcium stimulation test. Barabar? So you put calcium IV and then you check for the C-peptide level, insulin levels, all those things. So calcium stimulation test is a test we use for insulinoma. Okay?
Yes, sir.
Then what happens is that sometimes you may get the calcium test positive, but you still don't find anything on the imaging because the tumor is too small. The tumor is very small, but it is there. You have proved it via the calcium stimulation test. So now, how do you localize the tumor if the imaging is normal? You use something called as a selective arterial sampling. So some arteries go into the pancreas. Now you go into one of the arteries, put the calcium and see what's happening. कुछ नहीं हुआ तो वहां पे ट्यूमर नहीं है. You go into the other artery, you put calcium there. वहां पे डाल के अपने को मिल गया, इंसुलिन लेवल्स आ गया ऊपर, तो वहां पे ट्यूमर है. तो you resect that area. You can resect out an invisible tumor also. Isn't it beautiful?
Yes, sir. Yes.
This is the magic of science. You can't see the tumor, but you can still
resect it.
Amazing, huh? I'll send you the links of all these things also.
Yes, sir.
Correct? Huh? So
So,
उसमें
but
again this
calcium, but calcium will normally also raise like pancreatic enzymes, no? Because it stimulates those enzymatic pathways. So how will we come to know that this is like pathological? Because normal response will also be the same.
No, so there are cutoffs. तुमने कितना कैल्शियम डाला और उसके बाद कितना रिलीज हुआ.
Okay.
There are levels. तुमने इतना सा कैल्शियम डाला तो इतना ही बढ़ना चाहिए नॉर्मल में या नेसिडियोब्लास्टोसिस में. So basically levels होते हैं. ठीक है. So in nesidoblastosis, because it is not actually a tumor, it is like a islet cell hyperplasia. So the calcium increases, the calcium related increase in insulin is not so much, whereas in the autonomous it is much higher.
Achha.
And in the autonomous it is much more क्या बोलते हैं, random this thing. So उसमें क्या होता है ना कि there is something, so insulinoma का कैसा है ना, insulinoma just doesn't care what is the blood sugar level. वो कभी भी बढ़ सकता है. So there is some clinical correlation to that. I have forgotten. I'll send you the link. और इसमें क्या होता है ना, आइलेट सेल हाइपरप्लेजिया में क्या होता है कि जब तुम खाना खाते हो तो आइलेट सेल हाइपरप्लेजिया की वजह से ज्यादा इंसुलिन रिलीज होता है, बट इट इज पोस्ट प्रांडियल. In the fasting state, islet cells are not activated, so it doesn't cause too much hypoglycemia. So in islet cell hyperplasia, there's a postprandial hypoglycemia होता है, because the islet cells overreact to the sugar load. Whereas in insulinoma, fasting hypoglycemia is more common. It can be postprandial also, but fasting is more common than the acidoblastosis and islet cell hyperplasia. Correct. So I say these are all small things which, if you understand, you can correlate it with the clinical symptoms. तो मजा आता है, नहीं तो it's like just by hearting,
Yes.
right? So अपन काफी diversion ले लिए, but it is correlating well. That's why I explained all things together, and these are actually all interesting topics. So, so we were at parathyroid adenoma versus parathyroid hyperplasia. So adenoma is much more common. Hyperplasia is rarer. Hyperplasia happens in some of the syndromes. Which syndromes?
Men syndrome.
Men syndromes, yes. So men syndromes में adenoma नहीं है ज्यादा, men syndromes में hyperplasia ज्यादा है. ठीक है, men 1, men 2, men 2B सब है ना. हाँ. Then तो आई थिंक इस पे रुकते हैं, बाकी अपन वापस केस पे जाते हैं. तो कैल्शियम, विटामिन डी, पैराथॉर्मोन पे बहुत घुमा सकते हैं वाइवा. तो आई गिव यू जो मेन पॉइंट्स है सब बताए, और भी कुछ रहेगा तो बाद में बताता हूँ. I will go back to the case.
Yes, sir.
You've told Vaishnavi briefly what is the history.
So this is a case of a
एकदम briefly 2 लाइन में बोल दो.
हाँ sir. So this is a case of a 70-year-old woman with intermittent fever of 11 weeks duration and new onset back and leg pain. So back pain is on a scale of 0 to 10 is 10 and radiating to the leg. And she has a history of diarrhea for which examination of stool reveals Campylobacter jejuni, but she has not taken any antibiotics for that and it has resolved on its own. So now further
वगैरह कुछ हिस्ट्री क्या? Numbness and weakness का कुछ हिस्ट्री है?
हिस्ट्री नहीं अभी हाँ मतलब वही है, बैक पेन एंड फीवर एंड रेडिएटिंग टू द लेग.
पेन रेडिएटिंग टू
वीकनेस वगैरह का कुछ मेंशन नहीं किया है.
कुछ भी नहीं
अभी नहीं.
ठीक है.
अभी तक.
So at this point our differentials were TB, staph, pseudomonas of the spine. Rare possibilities would be salmonella, brucella. Other things discussed were like myeloma, though not fitting fully. Then
tumors which
yes, tumors का थोड़ा डिस्कशन किया हमने. बाकी तो कुछ नहीं. हाँ ठीक है. हाँ तो अभी वो फिजिकल एग्जाम पे है, बोलो.
हाँ, so she was
vitals are all normal.
Vitals are normal. She reported no weakness, sensory loss, or bladder or bowel dysfunction, or fevers on chills on admission. The patient was uncomfortable. The temperature was 36.2 degrees Celsius, and the lower thoracic spine, lumbar paraspinal muscles were tender to palpation. Vital signs and remainder of examination was normal. An ECG was done, which was normal. Radiographs of thoracic and lumbosacral spine revealed mild degenerative changes without evidence of fracture, compression deformity, or subluxation. She was admitted and started on ibuprofen, narcotic analgesia, and diazepam was administered. And she reported a decrease in pain to 4 out of 10, and she was able to ambulate without assistance. Oxycodone, ibuprofen, and a skeletal muscle relaxant was prescribed, and she was discharged home with instructions to follow up with the physician. So during the next 6 days, the pain in the lower back increased to 10 out of 10 and radiating to both the knees. Approximately 3 days before the admission, the temperature had rose to 39.4 to 40.6 each afternoon, associated with chills, sweat, abdominal pain, and a reduced appetite. The patient's family took her to a healthcare center associated with the hospital, where she reported that fever spikes were similar to those she had in the past in association with malaria. On examination, the temperature was 39.2, BP was 180/68, pulse was 102, respiratory rate was 20, and oxygen saturation was 99% while breathing ambient air. She there was discomfort in the right lower quadrant without rebound tenderness. Urine analysis revealed 50 to 100 white cells per high power field and few bacteria and squamous epithelial cells, and rest of urine analysis was normal. ECG was normal, and she was transferred to the emergency department of this hospital. On arrival,
we stop here.
yes, sir.
Now, what do you think?
Sir, so she has a typical afternoon or evening rise of fever along with reduced appetite and all these things. So it could be TB. The possibility could be Port spine or TB.
अभी नया चीज क्या मिला है अपने को?
यूरिन में पस
यूरिन में pus cells भी है. हाँ.
हाँ, so
So
how
it
will
could
you
also
correlate
be,
that with the rest of the history?
it could also
right
be
pyronephritis.
pyelonephritis, right-sided pyelonephritis, or urine.
Diabetic
See,
वगैरह कुछ है क्या?
back pain and paraspinal tenderness है ना, and its pain is radiating to leg. That will not happen in pylo. Barabar, but she's an elderly diabetic, so she may have had a urinary infection which caused a bacteremia, and the bacteremia seared the spine. बराबर. So अभी तो है pyuria, but previous episode में seeding of the back हुआ रह सकता है. 11 months of fever है ना, तो it can't be single episode. But once the organisms go to the spine, they behave in a chronic fashion. Like before Vaishnavi joined, I was telling them that although it's a chronic history, so you would think more of chronic organisms like Brucella, TB, and Salmonella, but in bone infections and joint infections, many times the acute wale germs also present in a chronic fashion because we don't know why, but that just happens. Like Salmonella, osteomyelitis, staph osteomyelitis can present very well with a chronic history, more than 4 weeks history and all. The same way, E. coli can also produce a chronic spondylodiscitis or a osteomyelitis of the spine. Okay, so that's one this thing. Again, the pyuria can also be due to a disseminated cox. There may be renal involvement. And the classic thing in TB we know is a sterile pyuria. You'll have pus cells, but you will not grow anything on culture. So then you will get something on the gene expert. Right? So these two things we can think of after the urine report. Huh? ठीक है, आगे बढ़ो.
On arrival, additional history was obtained. The patient reported that her fever had never completely resolved since the onset 11 weeks before and were associated with weight loss of 4.5 kgs and dysuria during the previous 2 to 3 months. So she had type 2 diabetes mellitus for more than 10 years, hypertension, hypercholesterolemia, GERD, headaches, chronic peripheral edema, vitamin D deficiency, osteoarthritis, and exposure to hepatitis B virus. She had a Helicobacter pylori infection 4 months earlier, for which she was treated with amoxicillin, clarithromycin, and omeprazole, and she has a history of malaria in the past. On initial immigration to this country 13 years earlier, a tuberculin skin test was positive, and she was asymptomatic and reportedly did not take isoniazid because of her age. Medications included atenolol, lisinopril, metformin, simvastatin, diazepam, ibuprofen, oxycodone, aspirin, ergocalciferol, and calcium. She has no known allergies. The patient has been born in East Africa when she was in her early 50s. She moved to a refugee camp for 5 years and then immigrated to the United States. Approximately 4 years before admission, she moved to the Middle East, where she consumed unpasteurized camel milk She had returned to New England 5 months before admission and lived with relatives. She did not speak English.
वो unpasteurized milk consume किया
Camel
तो
milk.
क्या
Brucellosis.
correct
Brucellosis. So
correct
she did not speak English. Her relatives interpreted for her. She did not smoke, drink alcohol, no illicit drug abuse. No history of exposure to ticks or pet or sick contacts. Her children were well. On examination, temperature was 36.8 degrees Celsius. Blood pressure was 150/60 millimeters of mercury, and other vital signs normal. There was tenderness over lower paraspinal muscles on right side with palpation and tenderness at costovertebral angle bilaterally, and no tenderness in the midline along the length of spine. The deep tendon reflexes and remainder of examination was normal, including the straight leg raising test, which was normal. Levels of platelet and red cell indices were normal, as were the levels of calcium, phosphorus, magnesium, bilirubin, proteins, globulin lipase, alkaline phosphatase, and tests of renal functions. Chest radiographs revealed elevation of right dome of diaphragm, which was new in comparison, right hemidiaphragm, which was new in comparison with studies performed 6 days earlier. Morphine and ceftriaxone were started for this patient. The patient was admitted to this hospital and respiratory precautions were instituted. On the first day, the temperature rose to 40 degrees Celsius, and a grade 2 by 6 systolic murmur was heard at the upper right sternal border. The examination was otherwise unchanged. A CT scan of abdomen and pelvis showed degenerative changes in the spine, most prominent at L5S1 level, and scattered subcutaneous calcifications in the region of buttocks, but was otherwise normal. T2 weighted MRI images of spine revealed hyperintense signal and enhancement involving the end plates adjacent to L5S1 disc space with fluid in the disc space, enhancement in paravertebral soft tissue, and probable extension into ventral epidural space at the level, and severe foraminal stenosis on the right side with compression of exiting L5 nerve roots. There were other mild degenerative changes at the other sides of lumbar spine. Urine culture grew few colonies of mixed bacteria, and the
so
administration of
so after the MRI we have alpha S1 involvement
involvement.
and we also have some paravertebral involvement and some mild epidural involvement. Correct? So
Yes.
now I think this kind of pattern is fitting more into TB and brucella rather than the bacterial. Bacterial में paravertebral epidural इतना नहीं आता usually.
Yes, sir.
But possible है, but slightly more in favor of TB and brucella. Okay? ठीक है, बोलो.
So urine cultures grew few colonies of mixed bacteria and antibiotics were stopped for the patient. Examination of thick and thin smears of peripheral blood showed no organisms. Screening test for respiratory virus antibodies to HIV were negative. On third day, the temperature rose to 38.2 degrees Celsius. Induration at the site of tuberculin skin test measured 10 millimeters in diameter at 48 hours. 3 induced sputum specimens showed no acid-fast bacilli. CT of the chest revealed multiple non-calcified pulmonary nodules of less than 4 millimeters in diameter, as well as a calcified subcarinal lymph node. Features consistent with the previous granulomatous infection. A transthoracic echo revealed no evidence of valvular vegetations. The results of serum protein electrophoresis and testing for rheumatoid factor were normal. Tests for HCV were negative, no Benz-Jones proteins detected in urine, and IGRA test to detect the release of interferon gamma in response to MTB antigen was negative. On fifth day, they performed a diagnostic test.
अभी इसमें ना हमारा हमेशा गलत आता है. The diagnostic test we say that they might have performed हमेशा गलत आता है, although diagnosis अपना 80% of the time correct आता है. So I think, but still we have to attempt. I think the diagnostic test they performed must have been a vertebral biopsy
possibly
of the involved area to send for everything, उसमें उनको मिला रहेगा TB या कुछ. TB most likely, second is brucella. बराबर?
yes.
Other thing you could do in such a patient is a urine gene expert. If you are really suspecting COX with a renal involvement. but अभी तक imaging में कुछ renal involvement नहीं बोला है, उन्होंने किया भी नहीं है. Sonography CT abdomen नहीं किया है, but keep that in
हुआ
mind.
था सर, abdo-pelvis
So,
में,
yes, so in the abdomen they didn't find anything.
nothing.
Nothing. In the chest they found some non-calcified nodules, correct? And they found a calcified subcarinal node.
Yes, sir.
Barabar. So now calcified subcarinal is suggestive of old TB.
Old TB.
But the current non-calcified nodules are suggesting activity. So now these kind of nodules are unusual for brucella. So TB most likely. But so NEJM वालों के लिए TB is a very rare diagnosis. अपने लिए
did the diagnostic test, which was a blood culture actually. So they took 3 to 5 days after incubation, blood culture grew the bacteria, brucella.
Correct. So गलत हो गया अपन. But good case, good discussion. But अपना पहला दो differential में तो था TB and brucella.
TB and brucella.
The lung nodules are a little strange for brucella. I guess हो सकता है. दूसरा nothing else is out of place in this. Brucella में हाँ वो maybe that pyuria and all was just a red flag. I mean it was a red herring only because brucella UTI नहीं करता मेरे ख्याल से. Brucella can cause orchitis. I'm not sure of UTI. Anyway, ठीक है आगे बोल क्या बोलते हैं वो.
तो वही डिफरेंशियल डायग्नोसिस में जैसे हम लोग ने डिस्कस किया, एक तो उन्होंने पायोजेनिक इन्फेक्शंस बोला है, सेकंड ग्रैन्युलोमेटस इन्फेक्शंस लाइक टीबी. सो इवन इन देयर केस ग्रैन्युलोमेटस में ट्यूबरकुलोसिस वाज ऑन द टॉप, एंड सेकंड दे थॉट वाज बिकॉज़ वो कैमल मिल्क की वजह से ब्रुसेलोसिस एंड unpasteurized camel milk.
Yes,
that is it.
Correct. ठीक है. So how do you treat brucella?
Doxycycline and ये
उसमें combination लगता है many of the times. It's a rifampicin, doxycycline, streptomycin combination ऐसा है कुछ तो.
Yes.
Streptomycin, amikacin. And you have to give treatment for 1 year. So undulant fever ऐसा सब उसमें आता है ये सब. So good case, good discussion also. And differential diagnosis में कुछ अच्छा टेबल या कुछ अच्छा पिक्चर या कुछ रहेगा तो ग्रुप पे डाल दो. हाँ
एक है सर, मैं भेजता हूँ. उसमें उन्होंने ब्रुसेलोसिस, ट्यूबरकुलोसिस, पायोजेनिक इन्फेक्शन, वो तीनों का डिफरेंशिएशन बताया अकॉर्डिंग टू द सिम्टम्स.